If you forcefully abduct the hip, you actually make the whole situation much worse. Because
even if someone looks wrong, they might be right.
the thing is, what is very important, I don't want external rotation. I don't want the knees out and the feet in at a narrow footrest. One of the biggest factors of hip migration in children with cerebral palsy is muscle imbalance and muscle weakness. So all muscles are weak. Whether they're spastic or not, they're still weak.
Pain is the number one thing that we want to prevent.
Hello and welcome to Wheel Chat. We are back and we are back big.
Anton, who do we have?
Oh, well, I'll tell you something. We are kicking things off massive this week because we're back. We're excited. This topic, I would say, is pretty much every clinician's sort of working with complex seating has probably wrestled with at some point, haven't they? Hip abduction in non-ambulant children. I guess if you've ever asked yourself, how much abduction is enough? How long should we be doing this for? Are we helping or are we potentially causing harm? You are definitely not alone because we have somebody today who's been thinking deeply about this exact question for, I would say, over 2 decades from my research. Dr. Mathias Axt is a pediatric orthopedic surgeon who has spent more than 20 years working in children's hospitals, focusing on hip development, surgical management, and long-term outcomes in non-ambulant children. No one better, genuinely, to ask the questions to. And really, what we're excited about is the experience that you're going to bring. Dr. Axt, welcome to Wheel Chat. We're excited to have you on. Good morning.
Thank you, Anton.
Good evening over here. Firstly, before we even kick anything off, Doctor, I just want to say, I heard your name years ago, just coming around, and I thought it was the coolest name for an orthopedic surgeon. When I thought your name was Dr. Axt, like A-X-E, I thought, what a cool name. Someone going around calling himself Dr. Axt, who's like cutting up people in surgery. And then I realized your name is it a German name?
Yes, it is a German name, Axt with a T, but it means axe. It's the same.
Oh, there you go.
It's basically
Okay.
the translation of axe into German. Yes, that's right.
I really wanted to come bring you on to you today because, like I said, I've heard your name out in the traps over the years, specifically when I have to seat a child in a wheelchair and I'm being told I have to sit the child with almost like 45 degrees of leg abduction. And it's inconsistent from what I've heard. Sometimes I hear they need to be sitting in this way for years. Sometimes it's just, for the next few months. And I'm not really sure. It seems like no one's really sure what the guidance is, but your name always pops up. So I thought it's a great person to ask. Question I want to ask is, and I want to get everyone who's listening today, if you are working with children, who are the children that need to sit in abduction? For those who don't know, abduction is when our knees go out to the side. Who are the people that need to sit in abduction? And why are we doing it?
Good question. How much abduction do you need? Well, I can only say it depends very much whether the patient has low tone or has high tone. And I can only say, regardless where the hip actually sits. And I can explain why hips sublux and dislocating children with cerebral palsy, but in children with high tone and high spasticity, where you barely can separate the legs, you cannot sit those children or place them into abduction because it will actually harm the hips. It will cause only stress, more stretch to those already spastic and tight muscles, and potentially pain and potentially too much pressure in the hip joint, So I have to do something to those hips first before you can allow them to sit in more hip abduction. And also, if a child has abundant range of motion, then it is actually not so important to have a lot of abduction. Only a little bit abduction is important. Why is that so? So first of all, the hips in a child with cerebral palsy, we're talking about cerebral palsy, these are normal at birth. So completely normal. And then over time, they displace and migrate outwards, out of the socket. But where do they actually migrate into and why? So first of all, muscle imbalance. So one of the biggest factors of hip migration in children with cerebral palsy is muscle imbalance and muscle weakness. So all muscles are weak. whether they're spastic or not, they're still weak. But there are muscles weaker than other muscles, and the weaker muscles are the hip extensors and hip abductors. Those muscles that drive the legs out and straighten the legs. These are the weak ones. And the muscles who bring the legs together, the so-called adductors, and the flexors who bend the hips, they are strong. So they cause an imbalance. And therefore, they drive slowly the hips upwards firstly and then outwards. And in children with cerebral palsy, more outwards. Okay. So if you then abduct the hips, then you actually redirect the ball more towards the center of the hip joint. And also another important factor is that the thigh bone at the upper ends, we talk about the neck and the shaft, is differently configured to a normal child. So we have a steeper angle between the neck ends and the shaft. It's called Coxa Valga. And we also have more rotation. We call this antetorsion or anteversion. So meaning that the neck is pointing forward. So that actually, when the child sits, really rubs more on the posterior rim and then helps actually prevents the socket to develop properly. So when you see that the hip slowly moves out, then you see that there is a steep acetabulum, because the pressure in those children with the ball driving up the socket is about 200 times as high as in normal children. So in Coxa Valga, and with high pressure, the rim cannot ossify because the cartilage cannot turn into bone because the pressure is simply too high.
No, sorry, before you continue, I just want to summarize where we're at so far, because you're saying some great things. I want to clarify that I understand. So right now we're specifically talking about children with cerebral palsy, not necessarily other conditions. So in cerebral palsy, they're at normal at hip birth, but after time, their hips migrate because there's a muscle imbalance and all muscles have been weakened, but some are weaker than others. And the ones that become weaker than others are often the abductors, the ones that allow your legs to go out. And so for that reason, our hips start to, the ball in the socket isn't going in the socket as much. As well, what also happens is that the neck shaft of the femur isn't developing in the right angle. So there's two things happening. There's the muscles that are pulling the joint out, the neck angle itself is not actually forming correctly in the acetabulum. Is that the word? That's the socket there?
The socket is the acetabulum. And because of the high pressure of the femoral head, the ball pushing against the rim of the acetabulum, that cartilage, which most of that in a small child is cartilage, but the cartilage wants to ossify, wants to turn into bone. That is the natural development of the hips. And that can't happen because of that pressure. It's actually the 𝐂𝐡𝐢𝐴 law not allowing physiological pressure in that hip joint, so the bones can't develop normally. And therefore the acetabulum, so the cup, as well as the femoral head, become displaced. And then once that has started, because there is less pressure when the femoral head points towards or into the soft tissues, into the capsule, it comes to a misshaped femoral head. It's rather square-shaped than round. And that's then, if you try to put the ball back into the socket, they don't really match anymore.
Round peg, square hole.
Yes. So the other thing is gravity. Gravity is an extremely important factor. As you know, children start typically walking around the age 10 and 14 months. And if that doesn't occur, then the thigh bone at the upper end, like the rotation, we call this torsion. So it's actually turning basically, if you look at my fist, turning forward. Baby is born with 30 degrees antetorsion, and it slowly, until adulthood, turns back into about 10 degrees antetorsion. And also, because of the lack of gravity, the neck shaft angle itself, which should be 128 degrees, is not being maintained, but it becomes steeper and steeper and steeper, because the muscles should drive the bones. Form follows function, basically, and the form of the proximal femur is not properly developed because of the muscles not driving the hip joints and not having concentric pressure within the hip joint. So there is persistent or increasing Coxa Valga, and there's persistent antetorsion. And that's part of the picture. So both parts, the thigh bone as well as the acetabulum, don't develop normally and become more and more what we call dysplastic and don't match very, very well after some time. Yeah.
All over from what you said, the muscles, all that stuff happened. I get that. Is that specific? So with the first part you said, is that a CP specific? And then the last one could be like spina bifida. Like someone with a spina bifida, for those who don't know, spina bifida, it's essentially like a spinal cord injury for a child where there's a similar effect. Do they also get these effects, or is it just the last one because they're not loading, the bone doesn't shape properly?
So spina bifida is a little bit different because spina bifida is they are often born with dislocated hips or subluxed hips to start with. Cerebral palsy hips are typically normal, but also other neuromuscular conditions, for instance, SMA is another big chapter. They are low tone initially, and then over time the muscles become rigid and don't allow the range anymore. And particularly hip adductors become tight, and the hip abductors, so hip adductors become tight and the hip abductors remain the same. So the child develops an adduction contracture, and that also helps because the child is still not walking, so the joint partners can't develop, and that also helps to drive the hips out. And typically, children with SMA have hip dislocations around the age of 5 or 6, but similar according to what we call gross motor function classification system. Hip displacement has a linear correlation with the severity of the disorder. Like GMS level 1s have 0, GMF level 5 children have 90% of risk of hip dislocation. And that has a big impact on this child because it often goes with pain and severe contractures at the hip joint and the inability, for instance, to standing or to this proper sitting,
And don't you go?
What I would like to do is really sort of move that forward and sort of understand, first of all, in terms of core principles, like what are the key principles you've developed over your, well, I've said 20 plus years of experience, but many, many, many years of experience. And also, can you just expand on the idea that Justin came up with? So I'm not going to call this one, Justin, this is yours, which is abduction is a tool, not a rule. Those would be a good kickoff for me.
Okay, so what we want to have is the hips safe in the depth of the socket. So you can imagine if we have what we call Coxa Valga, so the increase of the neck shaft angle from typically 128 degrees, we mimic, with abduction, we mimic the normal neck relationship, so the ball and neck relationship in the socket. Yes, the hips are in that case out, but that's also the reason why we, what we call, varise the hips. So with surgery, we change the neck shaft angle from typically about 140 to 150 degrees down to 115 degrees, okay, in severely disabled children. So that gives us a good head start, and then after that, the children don't need much hip abduction anymore. But with abduction, we mimic the normal relationship between the socket and the neck and the ball of the thigh bone, okay? Often what helps is, because how do we get there? We still need to release some muscles at an early stage. We do bone surgery only at a very late stage, typically around the age between 6 and 8, but soft tissue releases are important for those children at an early stage to allow the hip abduction to happen. Without that, and sometimes with Botox, with Botox, we get the legs softer in a better position to allow this abduction to happen. And then we can buy time. This is about not having a perpetual fix or like a fix long term, but we know that these hips often deteriorate still over time, but we want to buy ideally a time until they're about 6 to 8 years old, and we can do hip reconstructive surgery safely and long term. We have a good long term result. But until then, I want a little bit more abduction because I cannot change the angle between the neck and the shaft in these early stages, because I know with bony surgery that a relationship will return. So we have remodeling of the neck and the shaft in the future. So therefore, I advocate for at least 20 degrees of hip abduction each side to try to get the ball and the neck into a safe position.
20 degrees each side. It's a tool, not a rule. So is this for all children who are non-ambulant until they are 6? You would say because they're not weight bearing, and assuming that it's safe, that they don't have high tone where it's going to be dangerous. Yeah, so it sounds like there's a multiple reasons why children's hips migrate. The shape that we want isn't happening, and we can't do surgery yet. The bones haven't developed yet. So we want to abduct their legs 20 degrees until that happens. But it's not a golden rule for every child who's non-ambulant. It does depend on whether if they're high tone, then we don't want to do that. And if they're low tone, it sounds like we don't need to do that. Is that right? So even if they're low tone, we don't need to?
So low tone children still, SMA, for instance, it's still best if they have a pathological relationship between the proximal femur, so the top end of the thigh bone, and the acetabulum. I still want a little bit of hip abduction, but it's not so important because children with low tone, for instance, cerebral palsy, they have good hip abduction themselves, but for children who tend towards adduction on both sides, it's important to try to get them into a more physiological position. But what is also important, in an older child, we have a problem with pelvic obliquity and with scoliosis. And older children often develop what we call a Windswept deformity. And this is a real big issue because the Windswept deformity drives one hip, the hip which is adducted, out of the socket. But at the same time, when you sit the patient into a wheelchair, the pelvis rotates. GMFs level 4 and 5, they have a risk of 80%, so 70%, 80% chance of developing a scoliosis. And we don't know what drives what. There could be a little bit of asymmetry in the hips. There could also be just a neurological scoliosis starting to happen. And then we have more of a fixed rotation of the pelvis and obliquity. It becomes stronger and stronger. So if you look at the front, and this is actually really important, you see that if there's a Windswept deformity, that hip that is in adduction helps to push the same side pelvis backwards. So it helps rotating, but on the other hand, also the scoliosis helps rotating the whole pelvis, So let's assume the right ASIS is forward, the left ASIS is backwards. Can you imagine this? So the left hip is then adducted, and we have a Windswept deformity to the right.
Okay, your pelvis is essentially facing the left. So if your pelvis was a face, your face is turning to the left, and then your left leg is coming in towards the midline or beyond the midline. It's going in, and then the right leg is also doing the same. They're both going to the right. The face of your hips is going left, and your knees are going right. Yeah. Is that what you're explaining? Cool. Continue.
So the knee is going to the right. The left knee is going to the right. Exactly. In the right hip.
Yes. Yep.
So often we have also at the same time, the hip abductors on the right side being stronger. And if you then try to adduct the leg, you actually increase the pelvic rotation with the right side coming further forward. Can you imagine this?
Yep. So your right knee is going out to the side.
It looks like the right leg, you have a leg length discrepancy.
Correct.
For people driving and just understanding how this concept's looking in your mind's eye, it's presenting like a leg length discrepancy where the right leg's longer than the left. We're facing the left side, so everything's wind sweeping to the right, but the body is kind of pivoting a little bit to the left. Okay, so we've got that wind sweeping.
Correct.
And what you're explaining is by naturally wanting to abduct the left leg. So because we have that wind sweeping presentation.
Adduct the left leg, abduct the right leg. Okay. So in the Windswept deformity to the right leg is abducted. That also happens in the wheelchair, or tries to happen in the wheelchair, whereas the left hip is adducted. So inwards and going maybe across the midline. So now we have a huge dilemma because the physio tries to position the pelvis or the legs actually symmetrical, but that's something which we probably shouldn't do. We should allow abduction of the right hip, which is already abducted, and pushes and helps rotating the pelvis. And then, if possible, add abduction to the left side. Okay, if the hip adductors are not too tight, meaning you start with the right side basically out of the frame or out of the foot hangers. That's what we typically do. And then typically we have to help this often with surgery to release of the left hip adductors, those muscles who are contracted and bring the leg inwards. So to reduce that one, and this way also potentially reduce the hip or keep the hip in a better position. So in those children, we need actually more hip abduction than 20 degrees. That's what I'm saying.
Okay. After surgery.
Yeah, even in before surgery, the main principle would be to try to keep the pelvis neutrally rotated in the wheelchair. So both ASIs at the same point. And this is something which I see almost every time in clinic, and it gives me big grief because it's not considered properly. So the most important thing is that the pelvis is really correctly rotated. And then you let the one which goes into abduction, let it go into abduction, because you need to, this hip is safe, that hip is located, because the hip abductors preserve that hip integrity, but the other hip is at risk. The hip which gets pushed into adduction, so the leg inwards, that is at risk of dislocating. And that then needs to have the ability to get out as much as possible. Before the operation, you still can often get to at least neutral. So you need to try this. It will look asymmetrical because the right leg is abducted and the left leg is probably only to the midline. But it's better to have the asymmetry of the legs here. And after surgery, have more abduction on the left adducted and contracted side. And that may be that it's 30 degrees, for instance. And sometimes I have even more and have the foot hangers swapped. So I can actually then achieve more than 30 degrees of abduction, sometimes 40 degrees of abduction each side. It looks crazy sometimes, but that's how you keep those children pain-free. And, once the situation is stabilized, sometimes with the help of the spine surgeon too, you may revert the child later on again, but as long as the hip disease is driving one hip out, it needs the best possible position in the wheelchair to prevent hip dislocation.
I'll just share my screen and show you a before and after of a client, and to explain exactly what Doctor is talking about. What you're saying is basically, even if someone looks wrong, they might be right based on the hips. The priority is the hips. And so what you're saying is that we want a level ASIS, so that one's not more forward than the other. And if that means we have to let one leg go or two legs go, and it looks all the way out of the place, that's fine, because the pelvis controls everything. It controls your spine, it controls what's going on over here. So we don't want to sacrifice the neutral position of the pelvis so we can have a nice looking legs. We let the legs go if we have to. We want to bring the legs out, that means one abduction is fine. The adduction one is probably a tricky one, because if someone's contracted in an adducted position, like their knees going over their midline, it's going to be hard to bring them out of that. Like what you said, Doctor, you could probably bring it to neutral, but we got to do something to do the opposite, because the adduction is worse. Like, we've already got hip migration, and now it's like a lever that would pull into, like, pop it out of the socket, which is not what we want to do. So we got to do something to get it back in mimic the normal shape as much as possible. My question is, Doctor, I'm going to show you probably the most common cushion that we use for children with disabilities is a contoured cushion that allows the legs to be straight, right? And often as clinicians, wheelchair prescribers, we look at this and we want the kids' hips to be neutral, so we put them in a contoured cushion that is straight. For those who can't see what I'm doing, I'm just showing a Specs cushion right now, a high contour cushion, because it's a very popular cushion. Could be a Dreamline, could be any other brand, but essentially it's straight, where the hips are being flexed. They're kind of internally rotated because, that's what straight is. Is this what we want to be doing as a general rule, or should we be looking at cushions with more of a slightly more abducted shape? Is this good for general, or is it unlikely that some children who are non-ambulant should be in cushions like this?
If you, in these cushions, look at the width of the pelvis and then look at the width of the thighs, it's the same, meaning the hips in these cushions, yes, it looks like a pommel in the middle, but the hips are just at neutral. I see, in particular, when I see patients who just have an increasing what we call migration index with the hips slowly coming out, and I see this cushion, I want the hips to be in a little bit more of abduction. But with those pillows and cushions, I can't achieve it. I can't just cut something away from the pillow and allow more hip abduction. What I need is actually a more adjustable wheelchair where I can actually adjust thigh guides and also have the cushion contour or less contoured, so it allows me a wider range of hip abduction or from little abduction to a little bit more hip abduction. And for that reason, I personally prefer actually quite a flat pillow with a pommel and rather an adjustable pommel so I can actually get into the position I want the hips to be, That also means that sometimes, yes, I know the width of the wheelchair is often determined by the width of the pelvis, but I need the thigh guides to be adjustable and abductable in the wheelchair. I would like to have a wheelchair that has maximum adjustability. And yes, exactly. You show some of the examples here. That's fantastic.
I'm just pulling up a Specs constructor cushion that has a nice little keyhole. It's kind of like a hole where you can twist it and you can put a pommel in there and you can flex it out. And whilst that's good for the cushion, exactly what you're saying, doctor, the wheelchair doesn't accommodate that either. So it's quite tricky.
We have a certain position of the footrests. Often it's only one footrest where the board, that bottom board where both feet are resting on is actually one part. And you can't just widen the footrests easily or change the position, the width of the footrests. And sometimes, and actually quite often, we help ourselves of swapping the footrest so that then the feet are on the outside of the frame, which maybe is often, in many cases, actually too much, but we have no other choice. So we have to have more adjustability at the frame section to allow changing widths of the feet on the footrest, or as you just pointed here out, a footrest that is separable, so a right and a left footrest, and not just one board which seats or allows both feet to rest at the same time. So that's for me the worst case scenario and the least adjustability.
So a couple of things from a product perspective, doctor, this might make you feel better. So this chair that you see over here, this is a 𝐂𝐡𝐢𝐥𝐝, and this is called a contracture kit, where these leg rests can actually slide in and out. So the post is on the side and we can slide them in. So what that means is that we could have these posts in the middle and we can have the foot plates on the outside. So we can actually adjust how much that comes out. Not a lot of people do this because it's not designed for that, but it's super helpful. Like you can see from here, you could slide it. So we could slide this post in the middle of the chair and have the foot plates on the outside, which means we can adjust whatever abduction that we want. The second thing I want to show you that I think is interesting, this is a cushion mostly used for adults, but it's a very nice cushion because it's actually wider at the front than it is at the back. For those just listening, this is a True Comfort 2 cushion, not typically used in pediatrics. In fact, the smallest size it can go into is 16, or maybe 14 actually. But I love the cushion because it is narrower. Say if you had a 14 inches wide at the back, it would be 16 at the front. And then it has a bit of a pommel, and it also, the shape of it allows for a little bit of external rotation. I don't know if you want that, but it's a very nice, comfortable cushion to sit into for adults. And I'd love your opinion as to whether or not this would be a good cushion for children.
All right, first of all, it's a good starting point. And because the thighs are round, they always want to fall back into the same position. As I said, this is a good starting point. If you have the normal cushion you presented earlier, that doesn't allow more hip abduction because the bottom area of the thigh is always at the same point. And if you push the legs out, then it would sit against the side walls of the cushion, which is not good.
The worst.
Exactly. The other thing is what is very important. I don't want external rotation whatsoever. I don't want the knees out and the feet in at the narrow footrest, because
You don't want frog legs.
I don't want that. Why is that? Why is that? Because with the antetorsion or anteversion of the femoral neck and the head comes more to the front and pushes against the acetabulum even harder. I want rather mild internal rotation that allows the neck and the ball of the thigh bone to sit deep in the socket. I want at least neutral position with preferably even very mild internal rotation. That's the best way for the femoral balls to rest in the socket.
That's really great. I'm thinking, so if we had that rotation and you mentioned about the feet. So imagine we're in that frog leg position, okay? And you were saying, quite understand, we don't want that. We want to be able to derotate because we're in rotation. You don't want rotation. You want to derotate. What essentially would happen though is, from my experience and just me trying it as I'm sitting here, is that the feet, when you derotate, so if we're in that rotated position, if we derotate, we're going to bring the knees, we're going to adduct, we're going to bring the knees sort of closer together just naturally. We're not going to be able to control everything to have it into full sort of symmetrical midline. But essentially, would you accept the sort of, because of the rotation or derotating there, the feet might go slightly splayed out because of that? Because if you bring that rotation in, the knees essentially are going to come closer together, and you're going to have more of a splay at the bottom. Is that something that you would be comfortable with sort of accommodating rather than correcting, if that makes sense, going with that and having that sort of presentation?
So I'm actually happy if the foot width is as wide as the knees. So knee width is as good as the foot width. Then we have neutral rotation. Internal rotation may actually not be liked by the patients, because often the external rotators at the hip, because sometimes it can be that they like to be in frog leg position. That means that over time, muscles at the hip joint, so the external rotators, they become tight. And they may resist or find it not comfortable to have the knees in and the feet out. So for me, actually, as a general rule, the best position would be if the knees would have the same width like the ankles. That means that the footrests have to have really the same width like the cushion has, and also the thigh guides.
I want to tie this on to adults as well. And this is one of my clients who would love some opinion on this. Doctor, I just want to quickly show you. She has a subluxation in her right hip in this case. So in this case, do I just leave it, or is it better to try to still abduct it? At this point, what do we want to do with this subluxed hip? Just leave it or try to fix it?
Well, so we have a big dilemma. If it's a subluxed hip, the ball rides often at the acetabular rim. If you now abduct that hip, you tense up and stretch the hip adductors, the muscles that move the leg inwards. That increases the pressure of the femoral head against the acetabular rim and causes pain. So you can't do that. You can only do this if you salvage this situation. Either reduce the hip, release the muscles, or sometimes as a salvage procedure, which I occasionally have to do, unfortunately, you remove the ball surgically, so it won't ride against the acetabular rim, and that's probably the most terrible pain these patients can have. So if you forcefully abduct the hip, you actually make the whole situation much worse. So you can't do it. Yeah,
that's good advice. Just so everyone knows, the cushion that we did go with, I don't know if cushion was one of these. This is Specs Constructor cushion, where if I did a side-by-side screen, you'll be able to see that this is like a clear example where it looks like a leg length discrepancy, where we'd want it shorter on the right side, but it's not really shorter. It's just because it's subluxed and the bone's further back. So we've gone shorter on her right side and longer on her left side, and we've tried to do our best to adjust her leg over here. She's got these extra wide foot plates. This is as wide as these foot plates go, but we are trying to get her foot under her ankle. So it's good to know we're on the right track, but it's just interesting. Like, I'm sure a lot of clinicians would meet people in cerebral palsy where we didn't know the knowledge that we know now, and kids are just left to their own devices, and then they get these very difficult situations. So the idea is obviously to prevent this, but if we get this, then we just need to accommodate the position as best as possible without putting people in pain. Pain is the number one thing that we want to prevent.
I think we'll probably need to sort of round this up for this episode, but we would love to invite you back on if you were so in any position to give us any more time, because there's so much that we need to discuss about the practical application. So the theory, and then how do we apply that? Exactly what Justin was just describing with you and showing how he went from a presentation to actually applying that within a wheelchair base and then moving forward. So I think in closing, from my side, it's been unbelievable to actually gain this knowledge directly from an orthopedic surgeon, somebody who's working every day in this area and is hugely experienced within that. Justin, anything from your side that you want to say or close up with?
No, that was just really, really helpful, Doctor. And it is a challenge. Like, there is a conundrum of what you're proposing, like, especially when we've got active kids in manual wheelchairs where the leg rest, we can't move. Like, we can't always do these things, but at least we know what the North Star is and we can work backwards from there. We're trying to do this and we can come with creative ways to do it. And I'd love to work with manufacturers to build products like this, because it seems like most children, just to summarize, most children who are non-ambulant, meaning that they're not walking, should be in some level of abduction. And although the one I showed you, which does have a bit of abduction, it causes a bit of external rotation. We don't want external rotation at this young age. So something in between, Medifab, Sunrise, Autobot, 𝐿𝐴𝐿, whoever wants to chat, let's chat. If we can make a cushion, we'll call it the Axt cushion. That'll be it. That's the cushion. Let's call it that.
I think in closing, there clearly is a huge educational need that needs to be continued, because we as providers of the equipment who are assisting the occupational therapists and the physiotherapists really need to be collaborating even more than what we are. I think that's what I'm going to take from today is education, learn. Let's get the basic principles of seating and how we're going to actually use theory and collaboration to get that practical solution. I think that's a great way to end. Dr. Axt, it's been an absolute pleasure. Without putting you under too much pressure, would you come back on or consider coming back on again?
Anton, thanks very much for the invitation in the first place. Yes.
Now, of the Dr. Axt, I actually think this will spark a bit of conversation. I'm sure people will reach out to us with questions and clarification points. So we'll reach out maybe in a couple of months once the dust has settled and we've got some fresh ideas to chat about. But thank you again, Doctor. We really appreciate your time. I can't imagine how busy you are with all your experience and what you're doing at the hospital. But we, again, really just appreciate your time.
Brilliant. Thanks, everyone, for listening to Wheel Chat. You've been listening to Justin Boulos and Anton Mitchell. We are back for season 2. Get ready. This is just the start. Don't forget, it's so important to click like and
Just subscribe to the channel.
Subscribe. It's more important than you guys realize. I know that a lot of pods actually say that, but genuinely, the more we're doing this, the more we realize how important it is to get people like Dr. Axt on the pod so that we can just continue to learn. Guys, have a great rest of your day or beginning of your day. We can't wait for next episode. Check us out. Thanks, guys.
Thank you.
Thank you.